Blood is an active, volatile biological tissue. Every time a clinician initiates a transfusion, they are balancing the immediate physiological need to restore tissue oxygenation against the severe immunologic risk of infusing foreign antigens. To limit these dose-dependent immunologic hazards, modern medicine has shifted toward a restrictive transfusion strategy, a strict evidence-based approach to blood utilization. For hemodynamically stable patients, the minimum threshold to trigger a transfusion is 7 grams per deciliter. For orthopedic surgery or coronary artery disease, this threshold is bumped up to 8. For acute coronary syndromes, the target sits even higher, between 8 and 10. Adhering to these restrictive parameters is the most effective way to prevent a lethal transfusion reaction. Those thresholds apply to controlled environments. In severe hemorrhagic shock, the rules change. A massive transfusion means extreme volume velocity, requiring over 4 units of packed red blood cells in 1 hour or 10 across a 24-hour period. To anticipate catastrophic bleeding, trauma centers utilize predictive algorithms, like the TASH score, to calculate the probability that a patient will bleed to death without immediate intervention. Triggers for a massive transfusion protocol include lactate above 5, base excess below -6, or systolic pressure under 90. Once activated, clinicians target a hemoglobin between 7 and 9. Aggressive hemostatic support is mandated, targeting platelets above 50,000 and fibrinogen above 1.5. Massive transfusion protocols are designed to outpace exsanguination, but introducing such a massive volume of foreign biological material into a critically ill patient sets the stage for severe acute immunological reactions. In clinical hemovigilance, there is an absolute rule. Any new symptom or change in vital signs occurring within 24 hours of a transfusion must be presumed an adverse transfusion reaction until proven otherwise. This table outlines the 5 major post-transfusion reactions. Diagnosing them requires analyzing both the precise onset window and the exact constellation of symptoms. An acute hemolytic transfusion reaction, or AHTR, is a type 2 immune response. It is almost always the result of a clerical error leading to ABO blood type incompatibility. Preformed IgM and IgG antibodies rapidly swarm the donor red blood cells, triggering immediate complement activation, causing catastrophic intravascular hemolysis. This cellular destruction dumps massive amounts of free hemoglobin into the bloodstream. Clinically, it presents as a classic triad: acute fever, severe flank pain from renal papsal distension, and dark hemoglobin-rich urine. AHTR is an aggressive, rapid-onset crisis. Within minutes, the very fluid administered to save the patient's life actively destroys their renal system. Far more common, however, is the febrile non-hemolytic transfusion reaction, or FNHTR, which typically presents 1 to 6 hours after the transfusion begins. Instead of an antibody mismatch, this reaction is caused by white blood cells left inside the donor blood bag. During storage, these cells release and accumulate pro-inflammatory cytokines. When infused, this concentrated cytokine load triggers a systemic fever in the recipient. Crucially, FNHTR does not involve the destruction of red blood cells. The cells remain entirely intact. A type 1 allergic reaction, driven by IgE-mediated mast cell histamine release, occurs within minutes. This is severely hazardous for IgA-deficient patients. Affecting 1 in 700, they possess anti-IgA antibodies, requiring washed red blood cells to strip away donor plasma proteins. Differentiating between these non-hemolytic events comes down to timing and presentation. A fever hours later points to cytokines, while rapid-onset respiratory distress and urticaria point to histamine. The leading cause of transfusion-related mortality worldwide is a complication known as transfusion-related acute lung injury, or TRALI. TRALI operates on a 2-hit mechanism. Before the transfusion, hit 1 occurs. Systemic inflammation causes recipient neutrophils to migrate to the lung epithelium, sitting primed. Hit 2 is the transfusion. Donor anti-leukocyte antibodies bind to those primed neutrophils, activating a severe inflammatory cascade. The pulmonary capillaries become highly permeable. Fluid aggressively leaks into the lung interstitium, causing rapid-onset, non-cardiogenic pulmonary edema and severe acute respiratory distress. Because the resulting hypoxia is severe, clinicians must differentiate TRALI from transfusion-associated circulatory overload, or TACO. A normal brain natriuretic peptide, or BNP, strongly points away from cardiac fluid overload and directly toward the inflammatory lung damage of TRALI. This diagnostic process was formalized by the 2019 VLAR consensus criteria, which split the injury into 2 distinct categories: Type 1, where no acute respiratory distress risk factors exist, and Type 2. TRALI Type 2 allows clinicians to accurately categorize patients who develop post-transfusion pulmonary edema, but already possessed mild ARDS risk factors prior to the event. Correctly separating TRALI from hydrostatic fluid overload is a matter of life and death. Treating immune-mediated TRALI with aggressive diuretics meant for TACO will only induce hypovolemia and exacerbate the systemic shock. If an acute transfusion reaction is suspected, the initial response is universal. Step 1. Stop the transfusion immediately. Step 2. Maintain IV access with normal saline. Step 3. Perform a clerical check of patient ID. Step 4. Notify the blood bank and ICU. Once the line is closed, specific pathophysiology dictates the intervention. For an acute hemolytic transfusion reaction, the protocol requires massive, aggressive fluid loading to flush free hemoglobin and protect the kidneys from failure. For the cytokine-driven FNHTR, the intervention is simply administering antipyretics to reduce the fever. The actual prevention happens long before the infusion via the temperature-controlled leukoreduction of the blood bag during storage. Allergic reactions require pharmacological escalation, starting with antihistamines for mild urticaria and advancing directly to intramuscular epinephrine if full anaphylaxis and tracheospasm occur. Traley, conversely, does not rely on pharmacological reversal. Management is entirely supportive, requiring high-flow oxygenation and, in severe cases, immediate mechanical ventilation until the lung endothelium recovers. While downstream pharmacological treatments diverge wildly based on pathophysiology, the immediate physical action of stopping the infusion is the universal pivot point of patient survival. The danger does not end after 24 hours. Minor antigens like Rh or Kel can sneak past initial screening. Weeks later, memory B cells wake up, recognize the foreign antigen, and mount an anamnestic response, tagging donor cells for destruction by macrophages in the spleen. Because this hemolysis is extravascular, the clinical signs are subtle. Patients present with mild jaundice and a clinically silent, unexplained drop in their hematocrit levels. Management for a delayed hemolytic reaction is largely supportive. However, rigorously identifying and documenting the specific antibody responsible is mandatory. Any future transfusions for that patient must utilize specifically matched antigen-negative blood. Every unit of blood represents a profound physiological intervention. It requires clear physiological justification, rigorous threshold analysis, and vigilant monitoring. Clinicians must treat blood as a complex, volatile biological tissue, demanding absolute clinical respect, from initial threshold calculations to weeks after the final drop is infused. If a reaction is suspected, the response is universal. Stop the transfusion, maintain a saline IV, check patient ID, and notify the ICU. Next, target the pathophysiology. AHTR requires aggressive fluids. FNHTR needs antipyretics. Allergic reactions demand epinephrine. Traley requires oxygen and mechanical ventilation. While downstream treatments diverge wildly based on pathophysiology, the immediate physical action of stopping the infusion is the universal pivot point of patient survival. The danger extends beyond 24 hours. Minor antigens like Rh, KID, or Kel can sneak past initial screening. Days or weeks later, memory B cells mount a delayed anamnestic response, tagging donor cells for destruction by macrophages in the spleen. Extravascular hemolysis presents subtly with mild jaundice and an unexplained hematocrit drop. Management is supportive, but rigorously identifying the responsible antibody is mandatory to secure antigen-negative blood for future transfusions. Every unit of blood represents a profound physiological intervention. It requires clear physiological justification, rigorous threshold analysis, and vigilant monitoring. Clinicians must treat blood as a volatile biological tissue that demands absolute clinical respect, from the initial threshold calculation to weeks after the final drop.